Good afternoon, everyone. Welcome to today's Endocrinology Grand Rounds. Today we have Rebecca Jeun, who is one of our own faculty who will be presenting. Dr. Jeun joined us a couple of years ago and has rapidly become very popular both in the clinic and also as a educator. She works both here at UofL clinics and also now at the VA, and has now taken on the role of being in charge of the AIM clinic, the HCOC clinic, and also as associate program director for our fellowship program. She has an interest in general endocrinology, transgender medicine, and also in working with the Brown Cancer Center to try to develop some programs for endocrine oncology. So Dr. Jeun will today present about updates in the management of non-diabetic hypoglycemia, which is an interesting topic for everyone to learn more about as we see more and more of these patients. Thank you.
Thank you for the kind introduction, and happy to be here this afternoon talking with you all. Okay, all right, thank you. I don't have any relevant disclosures, but I will be talking a lot about off-label uses of different medications just because of how limited we are in our armamentarium currently. So just to go over the agenda for today, I'll spend kind of the first portion of the talk, since we have trainees with us as well, going over just some of the basics of the evaluation of hypoglycemia in patients without diabetes, understanding the differential for those patients, and working through the differential diagnosis and different frameworks to approach these patients. And then we'll kind of split these etiologies into insulin or insulin receptor mediated hypoglycemia versus non-insulin mediated. And then we'll discuss basically kind of our usual kind of treatment process for these patients, and especially focusing on the pharmacologic therapy. Most of this will be geared towards the insulin or insulin receptor mediated etiologies, is where a lot of the work is being done recently. And then we'll conclude with a little bit of a discussion about some of the newer agents that have moved through phase 2 and are in phase 3 trials for management of non-diabetic hypoglycemia for certain indications, including congenital hyperinsulinism and post-bariatric hypoglycemia, as well as islet cell and non-islet cell tumors. Just for if anyone's from the ped side, I will not really touch on the pediatric side of things since that's not in my wheelhouse, but some of the pharmacotherapy will be relevant to treatment of conditions like congenital hyperinsulinism and and some of the other etiologies that are seen more on the pediatric side. But primarily the treatments that we'll be discussing are more for the insulin-mediated etiologies. So just kind of to take a step back and review, as I'm sure you guys all are aware, blood glucose is very tightly regulated in a narrow range in the normal human body, and we have peripheral and central glucose sensors that register where the glucose level is. And so if there is a low glucose, then a series of neural and hormonal counter-regulatory mechanisms exist to prevent or ameliorate the hypoglycemia. And so that includes decreasing insulin, an increase in glucagon release from the pancreas, increase of epinephrine from the adrenal medulla, and the norepi from the sympathetic nervous system. And so in somebody without diabetes, not on any glucose lowering therapy, hypoglycemia is very uncommon. And so if you have spontaneous hypoglycemia or suspicion for it, that warrants further investigation. And so specifically, though, you do want to be looking at patients who meet Whipple's triad. So, this was described in detail as a sort of triad in the 1930s by Dr. Whipple in France. And so basically, you have to confirm that you have a truly low glucose level in the plasma, signs and symptoms of hypoglycemia, and the resolution of those symptoms after the plasma glucose concentration is raised. What makes it kind of tough is that there's no absolute level that defines hypoglycemia. And so you can't definitively say 45, 55, 60. Most people will have symptoms under 55, but that's not true consistently. So in your baseline evaluation, obviously you want to take a good history and go through the medication list carefully, comorbidities with paying close attention to a history of things like bariatric surgeries, especially the more malabsorptive things like Roux-en-Y bypass. And then even gastrectomies or patients with Nissen fundoplications, they can have alterations in their the speed of how food is being digested and can have issues with postprandial hypoglycemia. You want to pay attention to the timing that the patient is describing the hypoglycemic episode. Is it fasting or meal related or both? Any history of significant alcohol use, pertinent family history. And then, of course, on exam, you'll want to be looking for signs of hormonal deficiencies, any evidence of malnutrition, and then organ dysfunction. And so in the past, we had approached hypoglycemia maybe sort of way in the past as sort of split between fasting and postprandial. But we know that even in patients with insulinomas, even though primarily you see fasting hypoglycemia, a small percentage of those patients can have postprandial hypoglycemia. So you can't necessarily rule that out just based on the basis of fasting episodes or not. And then some of the Endocrine Society guidelines sort of recommend a framework to look at it. Is this patient well or critically ill? And that sort of differentiates what kind of diagnostic pathway you might consider. And then, of course, we can consider insulin or non-insulin mediated. So, in terms of the evaluation, of course, we would ideally like to catch them at a time of hypoglycemia and then get what we call the critical labs. So specifically the plasma glucose, insulin, C-peptide, proinsulin, and beta hydroxybutyrate levels, and then screen for oral hypoglycemic agents. In practice, obviously, as you guys know, very difficult to do this in the outpatient setting. And so a lot of times we will end up having to try to replicate these circumstances by either a 72-hour fast that's supervised in the hospital or mixed meal testing, depending on the pattern of the hypoglycemia. And then at any point, you can consider checking insulin antibodies to look for specifically insulin autoimmunity in specifically insulin naive patients. That doesn't require to be done. That doesn't have to be done at the time of hypoglycemia. And so this also doesn't kind of go through the hormonal evaluations, but obviously if you have suspicion for things like adrenal insufficiency or, this patient in front of you is in mixed edema coma, those are sort of more obvious kind of etiologies. So this is more for, the well patients that are coming into your clinic who are complaining of hypoglycemic episodes. Sort of how do we go through that workup? So, there's the classic 72-hour fast, the endocrinologist's favorite test and the patient's favorite test. You, of course, as the name sounds, basically have the patients document the start and stop time of the fast. Some institutions will have the patients start the fast at home, have them monitored in the clinic, and then sort of admitted. So that way they're not spending the full time in the hospital. So there's some variations on, how you can do this. But basically the patients can't be taking in anything that has calories. And so they're just allowed calorie-free beverages during that time period. You'll see this is the protocol published in JCEM in 2009. But I think some of this will be limited based on your resources. So a lot of times, instead of collecting these samples for all of these labs every 6 hours, we are just doing point of care finger sticks every 6 hours until the glucose starts dropping to around 60, and then increase the frequency. And just as a practical matter, patients you're admitting to the hospital, you probably need intermediate care, at least because of just like the nursing requirement. Once you get a lower blood glucose, point of care glucose, you need to be checking this every 1 to 2 hours until you get to a glucose that is less than 60. Send off all the labs, but you ideally want to get a glucose level in the plasma that's less than 45 to be very confident, and the patient has symptoms of hypoglycemia. I know practically we often end the fast a little bit earlier at like 50s, 60s range because people are getting symptomatic, and that's reasonable as well. They also recommend that you can actually stop the fast if the plasma glucose gets under 55 without symptoms, and that you might see in some healthy women or children, that you can see these levels with fasting without kind of a pathologic etiology. They also recommend in this kind of protocol doing a glucagon challenge at the end to see the response of glucose after giving glucagon. I think practically, I don't know that this adds a whole lot to our workup. You usually, if you are able to get a critical sample, you will be able to determine if this is hyperinsulinism or not. So not everybody will do that. So as you guys have all experienced, probably even this early into fellowship for our first years, obviously the 72-hour fast is a painful, resource-intensive, and difficult test for patients. And so there's been interest in, how we can maybe improve the experience or cut down the experience, basically. So the 72-hour, just so that you guys have the background of where this number comes from, is that we know from data from insulinoma patients in the 90s that 99% of these patients develop hypoglycemia within 72 hours. And there's some cutoffs in terms of the labs that were developed. And the insulin cutoff, I'm guessing with more sensitivity in the assay, have shifted from 6 to 3 at the time of hypoglycemia. And so there became interest in seeing if there was a biomarker that could be followed to end the fast early. And so that's where the interest in using beta hydroxybutyrate, which is increase in the fasted state if there's not insulin around, became of interest. And so there have been a couple poster presentations. Also, Cleveland Clinic just recently published on their QI project, basically adding a threshold of a beta hydroxybutyrate level of 2.7 millimoles per liter to as a cutoff to end their fast. And they seem like they had nice results with this, with about half of their patients being able to end the fast early. So this is from that paper. And so on the left-hand side, you have their using beta hydroxybutyrate in their protocol. So 68% of these patients, they had to fast them for the full 72 hours. But once they added in the cutoff of using the beta hydroxybutyrate, like I said previously, 50% of these patients could terminate the fast early and on average decrease the length of time by about like 8 hours, which is, important in terms of like the patient experience and hospital resources and nursing resources and that kind of thing. And then you still had about 27% of patients going through the whole thing, and then 23% of these patients did develop hypoglycemia within the time frame. And so this is kind of an example of the usual pattern that you would expect to see of the beta hydroxybutyrate in the fasted state in a patient without an insulinoma. And so that may be something that we want to be using more routinely. For postprandial hypoglycemia, there's some suggested, there's a lot of different protocols floating around from different institutions and from the same kind of guidelines. This is a suggested protocol for mixed meal testing. So some places will use like a nutritional supplement like Boost, or when I worked at IU, we used like a defined meal that they got from the cafeteria, or we told them to get this like specific meal from McDonald's to bring to clinic, and then we would do the testing. So supervise the patient comes fasting, and then you get baseline labs. And so we're also looking again, basically to try to provoke hypoglycemia and get critical labs postprandially to help make the diagnosis. So, just to kind of briefly summarize the general kind of etiology splitting in between a framework of looking at sort of ill patients or medicated patients versus seemingly well individuals. So, of course, you have drugs, different medications, which I'll show on the next slide, obviously insulin or insulin secretagogues. And then you can see hypoglycemia, which we kind of consider non-pathologic in a sense that it's not the primary issue in the case of more advanced liver or kidney or cardiac failure. In the cases of sepsis or severe malnutrition, and in some of these settings, you have decreased glycogen stores, and so that all is playing into that. And usually, that's more clinically apparent. Of course, from our perspective, different hormonal deficiencies, particularly adrenal insufficiency, but also, more severe cases of growth hormone deficiency or thyroid hypothyroidism, and then non-islet cell tumors and certain like sarcomas that are secreting IGF-2, or these are considered IGF-2 mediated oftentimes. And then if you have a seemingly well individual, coming into clinic, that's where we're looking a lot of times at the 72-hour fast to look for some form of endogenous hyperinsulinism, which the differential includes insulinoma, or they kind of labeled this under functional beta cell disorders, or the term nocidioblastosis. I think this is sort of controversial term in endocrinology, but some of these patients have more sort of pancreatic mass, and but essentially there is some sort of dysregulation in terms of the secretion of insulin and responsive glucose after meals, and so you see that in patients with particularly post gastric bypass hypoglycemia. And then we talked a little bit about insulin autoimmune hypoglycemia, which is mediated by antibodies to the insulin or the insulin receptor, which is quite rare. And then, of course, if they're accidentally or surreptitiously or somehow getting insulin secretagogue or insulin, but we won't talk about that today. And then these are some of the medications that have been listed with some evidence for association with hypoglycemia. I think in practice, we're not seeing a lot of patients on these drugs, so I don't know that this has come up, I think, clinically that frequently for me, at least. But these are, some of the things that have been noted in case series, case reports. So moving on to management strategies. So obviously, if we can try to target to the underlying cause, that's ideal. And so we kind of went through, this is from the same, a couple slides ago, the same breakdown of etiologies, but we'll focus more in terms of this part of the talk about the hyperinsulinism and sort of how we can address this. Of course, if there's an insulinoma, we would like to address this surgically if possible, but some of these patients have metastatic disease or cannot be, surgically treated. And then you guys have probably seen in your clinics the post-bariatric hypoglycemia patients. Surgery is not recommended nowadays for these. Historically, there's been attempts using like total or subtotal pancreatectomies, but that's no longer. But sometimes, patients have had reversals that haven't been effective, or they place even a G-tube into the remnant stomach. So there can be some alternative treatment strategies, but a lot of times I think when we get these referrals, it's for, we're often reaching for medical management upfront. So that's what I'll be talking about kind of moving forward. So diazoxide is a non-diuretic benzodiazide vasodilator. So this is one of the few FDA-approved medications. So this is approved for management of hypoglycemia due to hyperinsulinism in the adult setting for inoperable islet cell adenomas or carcinomas or extrapancreatic malignancy. And so the mechanism is that it controls insulin secretion by blocking the ATP-dependent potassium channels of the pancreatic beta cells, and then it's postulated that there's also an extra pancreatic effect that increases the hepatic glucose output. And so the dosing is 3 to 8 milligrams per kilos divided into 2 or 3 equal doses every 8 to 12 hours. I think a lot of times we're limited in the outpatient setting by side effects, primarily fluid retention. That people can get issues with palpitations and nausea, and then hirsutism in female patients. So one strategy is to prescribe it with thiazide diuretics to help prevent some of this fluid accumulation. So acarbose is another one another medication that we often reach for. So it was previously approved for use in type 2 diabetes. It's an alpha glucosidase inhibitor. And so the mechanism is that it is a competitive inhibitor of the pancreatic alpha amylase and intestinal brush border alpha glucosidases. So basically produces a delayed kind of breakdown of the ingested carbohydrates. And so the data shows that it does reduce the postprandial hyperglycemia as well as hyperinsulinemia. There's some data from a single controlled study in the context of specifically post-bariatric hypoglycemia. It is dosed with each meal. Frequently, you get GI side effects, so that is a limitation a lot of times in usage of acarbose. Another group of medications of interest is the somatostatin analogs, so octreotide and pasireotide. And so specifically in the post-bariatric setting, there's some data to support their use, but not officially approved for this use. But the idea is that they inhibit the secretion of insulin and GLP-1. And so there's also role for it in the context of insulinomas, especially those that express SSTR2. There is some differences in how octreotide and pasireotide bind to the somatostatin receptors. And so, sorry, it's kind of small, but so pasireotide binds to more of the somatostatin receptors, including 2 and 5. And so glucagon inhibition from the alpha cells is mediated mostly by 2. And so octreotide will inhibit both insulin and glucagon secretion from the islets, but pasireotide primarily, we think would suppress only insulin production. And so in one of the studies looking at post-bariatric hypoglycemia, which we see some of the results on the left side, this was in the context of a mixed meal test. And so the octreotide is in the open circle and pasireotide in the black circles. And so with pasireotide, you see a less pronounced rise in glucose, as well as a less pronounced rise in the insulin response. And the glucagon level is also higher, as expected, based on the mechanism that we were just discussing. Interestingly, there was a higher peak of GLP-1 just right after administration, but then dropped lower over the course of the test. And then at the end of the 180 minutes, the final glucose was higher in the pasireotide group. Now, the issue is that you had pretty significant hyperglycemia in this setting, up to I think 60s on this test. So that's something that hopefully dosing adjustment may be able to help dial in a little bit better. But of course, the somatostatin analogs are being used routinely for treatment of neuroendocrine tumors, and including the insulinoma patients. So these are some of the other drugs that are often mentioned that people will reach for, like verapamil particularly. So it's postulated to inhibit the calcium-mediated insulin secretion from the beta cells. And so in some case reports have been reported to reduce hypoglycemic symptoms in the post-bariatric hypoglycemia patients. Steroids, there's some case reports, but obviously that is limited by the adverse effects of chronic glucocorticoid therapy, some beta blocker, diltiazem, and phenytoin. But these are very limited in supporting data. Another medication of interest is amylin. So this is a beta cell hormone, normally co-secreted with insulin in response to meals. There's been a lot of interest in this, more so in like the type 1 diabetes setting to help manage postprandial hyperglycemia. But essentially, it has several effects that complement the action of insulin in regulating the postprandial glucose spikes. And so it does delay gastric empty and glucagon suppression. There was a study in 2022 using sub-Q injections of pramlintide and its dose TID, but it really didn't show a lot of effect on blood glucose excursions during a mixed meal testing. So that hasn't quite panned out so far. And then coming to another class, everybody's favorite GLP-1 agonist to use for everything. So of course, there's been interest in trying to use these drugs primarily because, so we know in the post-Roux-en-Y gastric bypass setting, the surgical alterations lead to basically nutrients entering the distal jejunum almost immediately. So there's a huge increase in the GLP-1 release and excessive insulin secretion. So we think there's a mismatch in the timing of this peak of GLP-1 and then the glucose level and leading to hypoglycemia. And so we know from some of the clinical studies that GLP-1 release is significantly higher in those who have had these kind of surgeries, and also those who develop hypoglycemia versus those who haven't. There was a systematic review from 2023, just pulling from a number of different case series. There are a few randomized trials or crossover studies. I think liraglutide and exenatide were used in some of these. I think basically we came out on the side of possibly helpful, but not like clearly efficacious. So again, not approved yet for this indication, but an area of interest here. So kind of summarizing all of those, a lot of those drugs, there's this interesting study from 2019 in one of the Scandinavian countries where they were looking at these patients with Roux-en-Y gastric bypass and postprandial hypoglycemia, and they basically were like, let's look at all of these medications. So they looked at the effect of acarbose, sitagliptin, verapamil, liraglutide, and pasireotide sort of in a sequential order and analyzed the effects of these medications on obviously the glucose response in a mixed meal test, but also with CGM data. And so they sort of had a baseline period and washout, and then went through kind of in randomized order, either acarbose, the DPP4, or verapamil, washed off of those, and then did the GLP-1 receptor agonism for 3 weeks, and then washed out again, and then did a single dose of pasireotide. So kind of a busy slide here, but essentially pasireotide, as we had seen on some of the prior slides, showed the most pronounced increase in glucose with some concern for hyperglycemia, but it was only a drug that the patients had time above the baseline, which response is in black, and then you can see that there was less insulin secretion compared to all of the other medications. And so that was only a drug in which the patients had glucoses primarily above the baseline in terms of the mixed meal testing. And none of the patients, when they were on pasireotide, had basically glucose time under the curve compared to the baseline study. And acarbose is in red, so there was less of a pronounced postprandial spike in blood glucose, as well as less in terms of the insulin production. Interestingly, that didn't really translate into the number of hypoglycemic events that they saw in the day-to-day, like CGM data. And then this is also a kind of similar idea, but essentially this is the insulin secretion rate, and then this is the level of GLP-1. And so pasireotide had the least amount in both of these settings. So kind of changing topics to another area of interest is using glucagon, but in a self-delivered setting. So this was a very small study done in 2020 using investigational, basically glucagon that was put into an Omnipod insulin pump, and they had their own sort of investigational algorithm during a mixed meal test where the pump was directed to deliver 300 micrograms of glucagon within 5 minutes based on the glucose trends reaching the threshold of intervention. And then if the system predicted or detected a second event, either 300 or 150 micrograms were delivered based on the glucose level being either below or above 75. And then so when the patients in the red line here, this is the patients with the Omnipod with glucagon in it. And so you see that there isn't as precipitous of a decline in the glucose as compared to if they just had placebo in the pump. So that's kind of an intriguing, study of potentially utilizing some of our newer diabetes technology to help these patients. And of course, I think most of us would be trying to get these patients on CGM therapy at baseline for self-monitoring, so they have oftentimes that piece of it. But how much further we'll go in terms of the actual using diabetes tech to deliver things like glucagon, I think remains to be seen. And here was another trial, but using basically self-administered just dasiglucagon injections. So they put these patients on CGMs. If they had a low glucose detected, they were instructed to confirm with a finger stick and then just give themselves an injection of glucagon. And so not too surprisingly, there was a decline in the amount of hypoglycemia related to this. So this was kind of interesting, just kind of proof of concept, but it's a bit burdensome for the patients. So moving on to some of the newer agents that have moved through phase 2 and are going to be in phase 3 trials. So this one is Exendin 939, or it's going to be the generic name will be avexitide, but it's a peptide fragment of exenatide, and so it's a first-in-class competitive GLP-1 receptor antagonist. And so in the early phase studies, it was done as an IV infusion, but they also have a sub-Q injection, and so it seems to be effective in preventing postprandial hypoglycemia and reducing neuroglycopenic symptoms during an OGTT. And that's what we're seeing on the left-hand side here. This is the IV form. This is the sub-Q form that will be probably the one that would be marketed for home use. And so in the black is the baseline kind of response. And so you see you have statistically significant higher glucose levels towards the end of the test, a little bit less so with the sub-Q version, but there is less insulin secretion with both of these drugs on board compared to baseline. So that's, I think, currently they're enrolling for phase 3 trials. I think the phase 2 was done out of Stanford, and so we'll see how much kind of the new data from the phase 3 studies will show, and if this will come to market. And then this is a drug called ersodetug. And so it's an allosteric insulin receptor antibody that's designed to inhibit the receptor overactivation driven by insulin or IGF-2. And so basically it is postulated to be quite helpful in basically any etiology that involves hyperinsulinism. So a lot of the trial data comes from congenital hyperinsulinism. They are using some of that early data to support actually moving quickly through, I think, into phase 3, and using that kind of on the basis that that data can extrapolate to tumor-induced hyperinsulinism. So that includes insulinoma or these non-islet cell tumors that make IGF-2, but cause hypoglycemia through the insulin receptor. And so basically the general idea is that it's an antibody that will reduce signaling at the insulin receptor and improve hypoglycemia. So the case reports that are being sort of presented in the poster setting, not quite in the literature yet, but they have an expanded access program. And so they have seen that several of the patients were able to basically be liberated from continuous dextrose infusions in the hospital or substantially reduce and let them get out of the hospital sooner. And so 4 of the 5 patients were able to completely stop dextrose support. And then 1 was able to achieve a 50% reduction. And so it's a promising, I think, new agent that will be interesting to see if we can get access to that for a variety of etiologies that are mediated through the insulin receptor. But essentially right now, I think probably the approvals will come for congenital hyperinsulinism and tumor-induced hyperinsulinism. So just to kind of conclude, a couple take-home points, I think as you guys probably experience in the clinic, these patients have a lot of morbidity from these conditions, and so can be very difficult to treat. A lot of times, obviously, our first line is going to be dietary interventions, but those are often difficult to adhere to or only go so far. And of course, we'll try to get patients on continuous glucose monitoring from a safety perspective, but that doesn't treat the underlying issue. And then as kind of we went through, a lot of the medications, that we have are either limited in terms of like dosing regimes or side effects profile, or not fully effective. And you can have some issues with both hyperglycemia as well as hypoglycemia still with some of these agents. And so I think more to come after some of these phase 3 trials are concluded. So thank you for your time and attention this afternoon. I'll take any questions.
That's a great overview. Thank you. So one question and one observation. So the blood glucose cutoff has always been a little tricky.
Yeah.
But I remember in 1960 there was a paper in New England Journal of Medicine by Mary Mead where they looked at healthy young adults, men and women, and looked when you fast them, like women could go as low as 45 and still feel okay, rather than just so that is a little tricky, especially when people want to wear CGM, they're healthy. So and then the second is the BHOV, which I think the way we designed ours was every 6 hours in healthy, not like the sick people, they call us like the healthy elective admission, just to get the BHOV trend over time. And the 2.7 cutoff 2 years ago, London was here at our ORC chapter meeting when she presented the data, which was published this year.
Yeah,
she got
when you make it,
award at that time, a poster one. It was a very nice study that was done, which was very helpful actually. And then my other question is about glucagon.
The glucagon injections,
So one of the side effects is the
nausea.
Right? So how did this in the study? Was that a problem, especially the ones they were doing PRN injections?
Yeah. I think they sort of characterize it as like mild and not limiting of therapy, but I think in practice that's going to be an issue that patients will run into. But I think because they're using like smaller, well, at least in the pump, like smaller dosing, maybe that sort of ameliorated. So in the one where they just looked at like the mixed meal testing, just like in the clinic, obviously that was just a short time trial. They haven't they didn't have like significant issues with like severe nausea, vomiting, but obviously I think that could be an issue that comes up in the real world if that is used. Yeah.
So these studies with postpartum hypoglycemia all pediatric.
Pretty much all the data, all the trials that I was looking at, because were essentially post-bariatric hypoglycemia. that's the biggest body of data so far, because, obviously that's a lot more common in terms of like the patient population.
So
I think
this
there's
is,
some data, there's a few studies here and there with like insulinoma patients, but more like case series or case reports, but primarily a lot of the more robust like studies were done in the post-bariatric setting.
So what is the current thing on idiopathic?
Oh, we had this discussion in the airport, is reactive hypoglycemia a thing? Yeah. I still don't know exactly where we fall on that one, to be honest, because
Most of our initiatives, like,
Yeah.
are elective.
yeah, yeah.
Can any of them get these,
Right. Well, the problem is I think all of these are off label. So getting these like in practice, I think is extremely difficult. So I finally got pasireotide like 4 months later. So it's not helpful by that time. And then
That was a tumor patient.
that was a tumor
Yeah,
patient, right?
not
Yeah,
a-
yeah, exactly. Yeah. So that was like, so I think the short answer is like, I don't know. It's those patients, it's hard to prove, I think, Whipple's triad in those patients sometimes, I guess, as like a first starting place. And then I think because I think in practice, like the mixed meal testing is sort of complicated to do if you don't have like a dedicated like endocrine infusion center. We often, I think I've done, we more counsel on like nutritional modification, and that seems to be helpful enough in these like mild situations. But I don't know. I guess I haven't seen like very severe hypoglycemia except in those patients who've had post-bariatric hypoglycemia, the ones that are sort of the population that we think may be sort of more obesity related or that kind of thing. I guess I haven't seen such severe. I don't know if you've seen more severe cases that warrant like sort of going down the route of trying to get some of these drugs for them. I've done acarbose. I mean, that's relatively easy to get, but I don't think I've had anyone be able to stand acarbose because of the GI side effects. Yeah. So.
So and you brought up the GLP-1, the one that AbbVie, whatever, the extended. But I have had in the endocrine society also like the regular, like they're pushing these GLP-1s that we have in the market as showing some effect. And your study from Stockholm or Scotland or wherever with all the drugs, sitagliptin, acarbose, and all that didn't have GLP-1, right?
It had liraglutide in
have
gray.
it.
Yeah, which it wasn't that impressive,
Yeah,
actually. Yeah.
The daily one, yeah.
Yeah.
I wonder if they did the weekly one.
Right. I think in some of there was a paper on semaglutide, which I think I didn't include in here, but there's some interest in the more potent, I think, ones.
No, because one of the things is because many of these so-called idiopathic prostatitis hypoglycemia are pre-diabetic, giving them GLP-1 actually makes them lose weight and it may fix the problem.
Yeah.
I'm not sure that it.
Yeah.
But, because I know that
to buy them.
Right. Yeah.
Metformin with a similar name.
Yeah. There's some case, I think, reports on using metformin and also SGLT2 inhibitors, kind of like the same idea to minimize the
Whatever you have
to help them ways. Yeah. I mean, these all, help lose weight and help, insulin. Yeah, help insulin
One thing about
sensitivity.
diazole said, of course, with the insulin surgery thing, but I have a couple of patients with generic lifetimes. And Proclastin is very expensive,
Oh, okay.
and these patients need a lot of it.
Yeah.
It's difficult to get it, especially when they become adults.
Yeah.
They have to keep taking it, otherwise they
Yeah.
drop.
Yeah.
I have one patient actually measured with the poster with the patient Dandy walk, right?
Is there any question online?
Oh, let me see. No, I think we're good.
Yeah, 72 hours.
Yeah, because the thing is that we had, it's difficult to convince the insurance company as to why they may be in the
Oh, even for the adult patients who have a known diagnosis of
Correct.
congenital
Yeah, the
hyperinsulinism.
People who review it, it's not in their algorithm. Have to do a peer.
Oh.
If they don't get it, then
That's
someone can
painful.
have hypoglycemia.
Yeah. Yeah, that's
And they need a
unfortunate.
lot of. Yeah.
Yeah. Well, I don't know that Ursodentug is going to be cheap, so
Yeah.
I don't know that that's going to be the answer. Yeah,
Hardcore was
yeah,
But if they compare, I mean, obviously this is less with sleep.
right. Yes, because it's less malabsorptive. Yeah,
Less and less.
Yeah.
Ru and Y.
yeah. Primarily, most of the data is Ru and Y bypass. Yeah, because of
Yeah.
the anatomy. Yeah. Mhm.
Don't you see this a little bit with your island patients also, because they undergo
They undergo, but theirs is a bit of a more complicated
complicated,
because
yeah,
of their
yeah,
hepatic items.
yeah,
Mhm.
okay, yeah, but they also sometimes.
I mean, the Pittsburgh group says a third of the patients will have hypoglycemia.
Oh wow. Okay. Yeah, I've had some patients with like Nissen fundoplications and then like gastrectomy have
Yeah.
this
that's
issue.
the
Yeah. Mhm.
To me, and the Bill Roth too.
Yeah,
Was done in
right,
70s.
yeah,
People
yeah.
forgot about it, but
Yeah.
you
Mhm.
find out that that's what.
Yeah. Mhm. Yeah.
Yeah.
Yeah. Yeah. Okay. All right. Thank you. Thank you.